Good morning, and a warm welcome to our public forum on pelvic floor health. I'm Dr. Chua Hong Liang. I'm a urogynecologist at KK Hospital. Today's meeting is brought to you by our pelvic floor specialists from SingHealth Duke Pelvic Floor Disorder Center. I would like to thank also our SGH Patient Liaison Service for coordinating this event. The SingHealth Duke Pelvic Floor Disorder Center specializes in the diagnosis and management of pelvic floor disorders. Pelvic floor-related conditions are common in our population. They may present in many ways. The commonest presentation in women is that of a vaginal lump. Besides noticing a vaginal lump, it can also present with urinary problems, bowel problems, pelvic pain, and sexual dysfunction. The care of these patients often requires specialists from many disciplines. Our multidisciplinary medical team include gynecologists, urologists, colorectal surgeons, physiotherapists, nursing and allied health specialists. This morning, we have lined up a good program for you. I hope you will gain a better understanding of the common pelvic floor conditions and their treatment from this meeting. Next, I will hand you over to Dr. Tan Ying Ru. She will start by introducing our speakers for this public forum. Ying Ru, over to you.
Thank you, Dr. Chua. Good morning, everyone. I'm Dr. Tan Yin Ru from the Department of Urogynecology at KK Women's and Children's Hospital. Today, we have a series of exciting talks by a panel of experts to address pelvic floor health. As you listen to the talks, please feel free to type in your questions into the chat box. Our speakers will address them along the way in the Q&A box, and we will also have a dedicated Q&A session at the end of today's forum. It is my pleasure to introduce our first speaker, Dr. Jill Lee, who is a consultant obstetrician, gynecologist, and urogynecologist at KK Women's and Children's Hospital. She is the program director of the SingHealth Obstetrics and Gynecology Residency Program and the clinical lead for the multidisciplinary combined pelvic floor and perineal clinics at KK Hospital. She will be speaking on pelvic floor across your life, from pregnancy to menopause.
Thanks, Yingru, for the kind introduction. Just give me a second to share my slides. Good. All right. Good morning again to everyone. I hope you can all see the slides. So let me kick it off by just talking a little bit about the background of this topic. So life expectancy for women in Singapore now is one of the highest in the world, with the life expectancy of 87 years for women currently in our country. So women take on many roles in their lifetime and are the backbone of society and families. Maintaining good health and quality of life is now a priority for most women, regardless of age or stage of their life. So today, my talk will cover how pelvic floor disorders can affect women differently across their lifetime. Firstly, we need to understand what is the pelvic floor. The pelvic floor is a dish-like sling of muscles that form a hammock, as you can see in the blue line, the blue dotted line, to support important pelvic structures like the bladder, uterus, and the bowel. When the pelvic floor structures, particularly the muscles or nerves, fail or work or don't work as well as they should do, then it can lead to pelvic floor disorders. And as Dr. Chua mentioned earlier, pelvic floor disorders can be very loosely divided into 4 categories. First being pelvic organ prolapse, voiding problems, defecatory disorders, and sexual dysfunction. Pelvic organ prolapse is when our pelvic organs start to droop through the vagina or through the rectum due to weakness of pelvic floor muscles. Stress urinary incontinence is the leakage of urine when you exert yourself, for example, when you cough, laugh, or sneeze. Overactive bladder, another type of voiding problem, is when one has an abnormal urinary urgency and frequency. And sometimes this can also be accompanied by a leakage of urine, which is called urgency urinary incontinence. Voiding dysfunction is the opposite, when urine cannot efficiently be emptied from the bladder, leading to urinary retention. Defecatory disorders, also known as bowel problems, can be related to the pelvic floor due to either poor control or leakage of stool or gas, which results in leakage of stool or gas due to weak muscles. But an opposite can happen when the muscles are too tight or not coordinated, where there is almost like a blockage of evacuation of your stools, which is called obstructed defecation. And sexual dysfunction is a difficulty with sexual intercourse, which can present in symptoms such as pain or lack of sensation. And today, the speakers after me will be sharing a lot more about these conditions and how they can affect you and what you can do about this for yourself. So as a woman travels through life, she will have moments where certain pelvic floor conditions become more common. These conditions become more common at different stages of life due to two main milestones: pregnancy and menopause. Pregnancy and menopause causes significant change in our body and can lead to some of these conditions. So today, I will focus my talk on discussing pregnancy and menopause in relation to pelvic floor dysfunction. So the female body is really very amazing to be able to bring new life to the world. Of course, to do that, it needs to have some adaptations during these magical 9 months. The pelvic floor and the urinary tract need to undergo many physiological adaptations during pregnancy. Our muscles, tissues, and nerves need to all become more stretchy. Some parts like the bladder and ureter get compressed. These changes then increase the susceptibility of a woman to pelvic floor disorders. And because pregnancy is a physiological thing, meaning it's a natural thing, many women do not report or underreport their pelvic floor symptoms because they assume that these symptoms are normal or are just too embarrassed to talk about these distressing symptoms. During pregnancy, hormones released by the placenta affect the biochemical composition of collagen and increase our smooth muscle relaxation. There is remodeling of our collagen fibers affecting the uterus, cervix, and pelvic floor, as well as the pelvic girdle, and can also increase the bladder neck mobility. So, of course, the process of delivery of a baby will change the pelvic floor in many ways. Firstly, the pelvic floor needs to stretch, and the pelvic floor hiatus, or the opening, which usually measures about 2.5 centimeters at rest, will need to stretch 3 to 5 times its normal size for an average size baby's head of 9 centimeters to come through. Next, there is ballooning of the hiatus of this opening, which can result in fascial defects, meaning stretch of the supporting fibers as the fetal head comes through. And from then, you can get neurological defects from compression of the nerves by the fetal head. And sometimes, unfortunately, when there's too much pressure, tears such as OAC or obstetric anal sphincter injuries can happen. And these tears will require suturing and repair by the obstetrician or gynecologist who's attending to you. As the baby comes through the pelvis and the birth canal, very high forces are required during pushing as well. And these forces are even higher when you need a procedure such as an instrumental delivery with vacuum or forceps. The areas that experience the most amount of stretch will be at greatest risk of injury. So actually, several pelvic floor disorders can arise as a result of this pelvic floor stretch and damage, namely as the 4 categories that we've talked about: pelvic organ prolapse, urinary incontinence, fecal incontinence and OFD, as well as sexual dysfunction. And some of these disorders then lead to other problems such as urinary tract infections, depression, and anxiety. And these pelvic floor disorders may then, some of them may even present very soon after delivery. For example, voiding dysfunction, which is when you have lacked the sensation of knowing when you need to void, or completely being unable to pass urine despite having a full bladder. And this can happen very early in the first days post-delivery. Fecal incontinence, which can happen due to injury to the sphincter muscle, which is the two rubber bands that hold your bowel continence. And if a tear were to happen then, or extreme stretch, again, a lady could lose control of gas or bowels. And this can, of course, be very distressing for a new mom. However, some of these symptoms or some of these conditions will only present months or years or even decades later. So it is really the impact of pregnancy truly leaves an effect on our body throughout life. But these conditions are very common, and as mentioned, they cause significant bother, but are really very underreported. The likelihood of developing pelvic organ prolapse in a woman's lifetime is actually 50%. 1 in 2 women will develop pelvic organ prolapse, but certainly we don't see 1 in 2 women presenting to our clinics. So what about menopause? So I mentioned that I will cover this as well. So menopause is the second major life event that significantly changes our pelvic floor function. Menopause is diagnosed when a woman goes through 12 consecutive months without a period. The lack of a period is due to a depletion of eggs from our ovaries and results in the level of the hormone estrogen falling in our body. Estrogen is a very important hormone as it plays a significant role in maintaining strength and elasticity of our tissues, including the pelvic floor muscles and the vagina. As estrogen levels fall, our tissues become thinner, less elastic, and weaker. So again, expectedly, these pelvic floor disorders can arise due to the pelvic floor changes due to menopause. Again, all 4 categories can be affected by menopause. Menopause alone can result in women developing these pelvic floor conditions even if they have never given birth before. It's common misconception that women can only develop pelvic floor problems or prolapse after having children, but that's not always true. Other risk factors such as obesity, chronic coughing, or chronic straining can increase a woman's risk of developing pelvic floor disorders like pelvic organ prolapse and urinary incontinence. So sometimes menopause in combination with the effects of pregnancy then result in the presentation of the symptoms of the condition that already started somewhat soon after the birth of their babies. So it is really important that women pay attention to their health and their symptoms, particularly in the area of pelvic floor dysfunction. Things you could look out for are whether you can feel a lump coming from the vagina, or you're starting to notice that the control of your urine is not as good as it used to be, whether it is in relation to exertion or just the ability to queue for a toilet, or the sensation that when you pass urine, it just doesn't feel complete. I think in these areas, especially sexual dysfunction, it can be a taboo topic, particularly in our community, but it is a very real problem and can affect women of all stages. It is not, again, something that we expect to only happen in younger women. We also know that older women also similarly suffer from sexual dysfunction with due to pain, reduced libido, reduced satisfaction, or even reduced sensation. So many women, again, hide their symptoms on the assumption that these are normal, but I think it is time we've moved on as a community and as a to look for these symptoms, and we want to aim for a better quality of life, especially at a time after menopause when you're looking to enjoy life and pursue your interests. We want you to have as good health and to be as fit as possible to do all the things that you wish to do. So, what can we do to prevent pelvic floor dysfunction? So, as I mentioned earlier, there are some general things that you can do, and these principles are to be kept across your lifetime, and that is to maintain a normal BMI. A normal BMI is a BMI of less than 25, between 18 to 25. So being overweight or obese is a problem, but being underweight, having a BMI less than 18 is also a problem because your tissues and muscles may not be very strong when you're underweight. So, and as we know that there is a war against obesity, and with obesity causing other medical problems, it is really important to also consider that pelvic floor dysfunction can increase with increasing obesity. One should avoid heavy lifting, but sometimes that's not always possible. So then it is also important to learn to lift with the correct technique and strengthen your core muscles that can help you lift in a better way to disperse the pressure on the pelvic floor. I'm sure Shu-En will be discussing further on this topic later in this webinar. Smoking should be avoided for two reasons. One, smoking can affect can cause chronic coughing, which will increase intra-abdominal pressure, causing strain on the pelvic floor. Secondly, smoking also weakens your connective tissues and can result in weaker pelvic floor muscles as well. And it is recommended that you can do pelvic floor exercises throughout your life regularly, even if you don't yet have any pelvic floor dysfunction. Pelvic floor exercises will include both strengthening as well as relaxation to ensure that the pelvic floor can do all the things that it needs to do in terms of having strength as well as the ability to relax to evacuate our bladder and bowels as we need to. During pregnancy, it is now important to routinely discuss obstetric-related or pregnancy-related pelvic floor dysfunction with your doctor during antenatal visits so that you can better understand your own condition. There are also special antenatal pregnancy-related pelvic floor exercises that you can do, which can reduce your chance of developing pelvic floor dysfunction after delivery as well as in the longer term. Things like perineal massage, which is massage of the vaginal area from 35 weeks of pregnancy onwards, has been shown to reduce severe perineal tears, which of course can then reduce the impact of pelvic floor dysfunction after delivery. Again, avoiding excessive weight gain. It is usual to expect to gain 10 to 15 kilos for every pregnancy, but it's also important to make sure that post-delivery, the weight does come back down to the pre-pregnancy weight. And then if somebody does really have terrible pelvic floor dysfunction or deemed to be extremely high risk, one can consider a cesarean section, but certainly it would not be routinely recommended because cesarean section carries in itself significant surgical risk and it doesn't mitigate the fact that pregnancy alone, the carrying of a baby in your tummy for the 9 months will already cause some changes to your pelvic floor, including all the hormone-related changes to your connective tissues. And what about menopause or the perimenopause, around the time of menopause? Again, a lot of women find that the biggest problem in menopause is weight gain. So it is really important that if you focus your effort to also maintaining your normal BMI during this time. Drinking fluids in a reasonable quantity. It's important to drink water sufficiently so that to avoid constipation. However, it is also there is a limit to how much water one should drink, because if you start to drink more than 2 or 3 liters in a day, then you would end up visiting the toilet very frequently, and sometimes that can affect difficulty to control your urinary function. Maintaining an active lifestyle with regular exercises generally improves your muscular strength, but it also improves your gut motility and helps you get to the toilet more regularly without straining. And again, pelvic floor exercises can be done and should be done routinely every day. So as you can see here, Women suffer from a variety of pelvic floor disorders affecting several body systems, with certain periods of their life being more at risk of different types of pelvic floor disorders. So care for pelvic floor disorders can be simple with those methods that I've mentioned earlier to prevent or to reduce the impact of pelvic floor disorders in your life. However, if you were to develop more complicated conditions or more severe conditions, you may also require expertise from a variety of specialists, especially if you have multi-compartment problems. As Dr. Chua mentioned earlier in his introduction, at SingHealth, we're lucky to have a pelvic floor disease center where we bring together all our pelvic floor dysfunction experts, whether they are urogynecologists like myself, or obstetricians, gynecologists, colorectal surgeons, pediatric surgeons, gastroenterologists, physiotherapists, specialist nurses, urologists. We're all under the same umbrella, and this helps us better meet individual needs because pelvic floor dysfunction can present in so many different ways. Also, our team, having this team allows us to discuss the more complicated cases so that we can really achieve the best solution for every individual. So now, what should you do if you suspect you might have pelvic floor dysfunction? Should you think you might have any of the symptoms that I have mentioned earlier? You can book an appointment with your GP or polyclinic for an initial assessment with urine tests and a physical examination. And sometimes many GPs can also start you on some medications for conditions such as overactive bladder or constipation. And if the symptoms don't improve, then you can get a referral to see a specialist. And which specialist should you see, since I've mentioned so many? So if you have pelvic organ prolapse, the usual specialist you should see is a urogynecologist. If you suffer from urinary incontinence, that means you have poor control of your urination, then you can see either a urogynecologist or a urologist. For fecal incontinence or constipation, it is best to see a colorectal surgeon or a gastroenterologist. And the difference between the two depends really on what is the cause of the bowel symptoms. And for sexual dysfunction, you should see a gynecologist or a urogynecologist, a psychologist, or or dedicated pelvic floor physiotherapist. And again, we have all our specialists under our umbrella at SingHealth. So it would be it's not too difficult, although it looks like a lot of different big names and big titles. It's actually a lot simpler once you recognize what symptoms you have and then letting your GP know, and then they can make the necessary referrals. So do pay attention to possible triggers, because one of the questions you will get asked in the clinic when we see you is, what do you think triggers your symptoms? So things like your diet, how much fluid you take, what activities you do, and your sleep. Those are things that we will ask you, and be good if you could pay attention. Sometimes if you can modify some of those things that you know are triggering your symptoms before you even come to see us, you may find that your symptoms are already better. However, some red flags is if you see any visible blood in the urine or feces, or even from the vagina, do see your specialist early and not delay, because sometimes there can be more sinister causes for these symptoms. And consider what you need and what you want before seeing your doctor, so that we can tailor the treatment accordingly, because there are a variety of treatments that can be offered now. And the aim really is to live happier and to be able to do all the activities that you want to do. So I thank you very much for your attention and logging in so early in the morning on a Saturday. And I will hand this over back to Dr. Tan In Roo. Thank you.
Thank you, Dr. Lee, for taking us through pelvic floor health across a woman's life. Our next speaker is Dr. Lee Xin Yi. Dr. Lee is a consultant in the Department of Urogynecology at KK Women's and Children's Hospital and the SingHealth Duke-NUS Pelvic Floor Disorders Center. Dr. Lee has a special interest in the prevention of pelvic floor disorders by promoting awareness and early intervention in the antenatal population. Dr. Lee will be speaking about urinary incontinence, a very common but overlooked condition. Dr. Lee, please.
Thank you very much, In-Roo, for the kind introduction, and a very good morning, everybody, for coming to join us on a Saturday morning to gain more knowledge and awareness about pelvic floor problems. And also thank you, Jill, for giving us a very good overview and summary about the issues that women may face during their entire lifespan with regards to the pelvic floor. I will now talk a little bit more and zoom in a little bit more about this topic of urinary incontinence, which is indeed a very common problem, but also a very common overlooked problem. So let's just start by getting the definitions right, okay? So what really is urinary incontinence? It is where there's an involuntary loss or leak of the urine because of a loss of bladder control. And there are various different types of urinary incontinence. So there could be stress incontinence, where increase in the tummy, in the pressure in the tummy presses on the bladder and the pelvic floor and causes leak of the urine. Or there could be an urgency incontinence, where the bladder is suddenly not able to control itself and then the muscle contracts and causes a leak of the urine. And of course, there's mixed incontinence, which is a combination of both. And there's overflow incontinence, where the bladder is unable to completely empty itself when you actually pass urine. Okay, so at this point of time, I'd like to take the chance to get everybody to get their fingers moving, okay, and participate in this very simple poll, all right, which is, have you ever experienced, no matter at any point of time in your life, whether it's younger days, pregnancy days, currently, etc., experience any form of urinary incontinence in your life, okay? And just, it's a very simple yes and no. Men, if any men are logged into this webinar, are also welcome to participate and give their answers. And we will get an idea about how many people in our audience today have ever been or is still currently being bothered by this problem. Okay, so I'll just let the poll run for another 10 more seconds, and then we will close the poll and see what is the situation at hand in our audience this morning. Okay, great. Let's take a look at the numbers. All right, so we have 500 people who have responded, which is great. And of these 500 plus people who have responded, 70% of us have said that we ever experienced urinary incontinence in life. So I think my talk will be very helpful and useful to a majority of the audiences here. Okay, so what are the international numbers really? Okay, so you are really not the only one. Like Jill already mentioned in her previous talk, okay, 50% of adult women will at some point of time experience bothersome urinary incontinence. But of note, something very interesting is that of these 50% of adult women, which is so many people, only another quarter to maybe half of these people are going to seek help. So why is that the case? That is usually the situation because we think that these symptoms are somehow or rather normal, something to live with, something that you will just have to deal with as you get older or as you become pregnant. Okay. And there's also a certain degree of embarrassment and fear if you have to go and see a doctor and talk to them about things at the private part area, or things that are a bit more sensitive, or to you feel a bit more embarrassed to talk about. I even have patients who say that they went to see doctor a few times, wanting to seek further referral for this problem. They walk into the room, they see a male doctor, they freeze, and then they left the clinic consult and waited for another few months, So there's a lot of embarrassment that could result in a delay in seeking care. And another concern that, that has been brought up is that some patients are not aware even that there are actually treatment options which could be easy and could be effective for their urinary incontinence problems. And so due to a combination of all of these factors, we do have a very high prevalence, or rather this is a very common problem, but it is not something that everybody is actually dealing with or seeking help for. So many people also feel that, oh, urinary incontinence, just a quality of life problem. If I can live with it, if I can deal with it, then okay, there's no need to see a doctor. There's no need to do anything about it. But is this truly just quality of life? Because actually many studies have been done internationally, and we do know that this is not purely a just quality of life issue. Okay, so clearly there is no doubt that there is it will affect the quality of life for people who have incontinence. You have to avoid doing certain sports activities, just so that you don't have any embarrassing leaking episodes in public. Some people don't even have to watch a comedy because once they laugh and they cough and they sneeze, they will leak urine, and that's very embarrassing. So this is definitely a compromise on quality of life. At the same time, there are also some patients who will experience urinary incontinence if they were to have sexual intercourse, or they may have a sensation of wanting to pee very overwhelmingly when they have sexual intercourse. And obviously due to that and the fear of leaking urine during sex, they actually completely avoid sex. And this can result in, problems with self-esteem, with inadequacy, and also some relationship problems for some patients. Right. And just like how, when babies are always wearing diapers, they are at an increased risk of having diaper rash and dermatitis. The same way, if adults have urinary incontinence and their skin is always in contact with a wet diaper or wet pad, they also can have very severe skin infection, dermatitis, diaper rashes, which need to be treated. And obviously all of these problems put together, if the patient is also unable to fully take care of himself or herself, then this would result in a lot of stress for the people who are taking care of the patients as well. And of course, all of these things also all chalk up various costs in terms of the treatment options required, the modifications required at home to deal with incontinence, or to even buy incontinence pads and incontinence sheets to put on the bed. All this also will work up to a significant healthcare cost. And as a matter of fact, some studies have even interestingly pointed out that patients with severe incontinence have somehow been associated or related with shorter lifespan than those people who do not have. So, all this is to bring to light the fact that urinary incontinence is not so much an unimportant and benign issue that we can completely ignore. Okay, so now I shall just zoom in to talk about the more common types of urinary incontinence, okay, and we shall start with stress incontinence. So stress urinary incontinence, or we short form it to SUI, is where you have an involuntary loss of urine when there's increased pressure on the bladder, okay? And this increased pressure can come from various types of activities such as exercising, okay, sneezing, coughing, heavy lifting, all right? And this is most common in the younger age group. It first appears or is first reported in the most in the 45 to 49-year-old age group. So the risk factors for SUI, or rather what are the things that can make SUI worse, all right, are the whole list of issues that are listed inside the slide here, okay? And as you get older, as you undergo menopause, you definitely have a higher risk of experiencing SUI. Right? Patients who have delivered more children, and the mode in which you had delivered more children, for example, if you had a forceps delivery or vacuum delivery as compared to someone who underwent a cesarean section, would also be at a higher risk of having SUI, okay? And then there is also the birth weight of the children at the point of time they were born, okay? And any history of birth trauma or very big tear in the pelvic floor muscles during birth can also increase your risk. Okay. Additionally, we also have to look at other factors such as your weight. Okay, if you have any history of chronic constipation or coughing, that would also make the situation worse. Your occupation, if you have to do heavy lifting, or if, for example, I have patients who are weightlifters and gym instructors, their occupations will also put themselves at an increased risk. Okay, and if you do heavy lifting, housework, squatting very regularly during the course of your daily activities, this can also amount to an additional risk factor. So, of note, what we should actually think about is that of all these risk factors, the stuff on the right-hand column under this big pink light here that says modifiable are things that we can actually change. And these are also things that we will advise you to work on when you come to us initially to seek help. So what will happen when you actually see a doctor? What happens in clinic when you come to see us? Okay, so first and foremost, we will speak to you and we'll get a history from you, or rather we will find out what's happening. What kind of symptoms do you experience, for how long, for how severe, how much impact it has on your life, okay? And why is this very important? Because essentially it helps us to know what kind of incontinence you have, because like I mentioned earlier, there are various different types of incontinence, and some of us can have more than one type of incontinence ongoing at the same time. So it helps us to know which type you are experiencing, how severe is the situation, and how much it impacts you. And of course, also what are your goals of coming to see us? What kind of treatment that you would like to have, or that you are considering, and that would be very useful in helping you come up with a personalized treatment plan. Okay, so after speaking to us, then what we will do is we'll do a body check for you. And for patients with stress incontinence symptoms, we may ask them to do an erect stress test, where we will stand and cough and see whether or not there's a leakage of urine, or we will do also a cough test when we are doing a gynecological pelvic check for you. Thereafter, you may or may not actually have to go through some additional tests to confirm or exclude the diagnosis. Okay. So if, let's say, you have been diagnosed with stress urinary incontinence, then we will of course talk about the treatment options for that, okay, which are mainly divided into non-surgical treatment options as well as surgical treatment options. So for non-surgical treatment options, we will always talk about doing pelvic floor exercises, okay, and in the subsequent talks later this morning, we will have our physiotherapist who will give us a very good rundown about PFEs, what to do, what not to do. Okay, so it'll be very good to listen out for her talk later. And at the same time, if you need any like online resources, we also have on our SingHealth website, advice about how to do pelvic floor exercises. And also we have on our hospital YouTube channel, a very good video about pelvic floor exercises. So these are all places where you can get your information and education from. But there will also be a group of us who are not very sure. We are trying to do pelvic floor exercises, but we are not very sure whether we are doing it right. So for this group of us, okay, then we will always refer you to see the physiotherapist to have supervised pelvic floor muscle training, okay? And like I mentioned earlier, correction of risk factors is very important. So for all patients, we would and if we identify any modifiable or change risk factors that can be changed, we will remind you about it and suggest you to do them, okay? And there are also some pessaries that are available specifically for treatment of incontinence, okay, where there is a knob on the ring pessary as shown in the top right-hand corner of my slide here, okay, which helps to kind of kink the bladder neck a little bit so that it reduces stress incontinence. Okay, so these are some options that are there. So this is a slide of the pelvic floor exercise that we actually have on our KK YouTube channel. Highly recommend you guys to go in and look at it if you have any interest and if you want to revise the stuff that we talk about today.
Demonstrate.
And then, of course, there's also surgical treatment options, okay, which we mostly perform the mid-urethral slings here in the KKUG department, okay, where there are various different options of mid-urethral slings, and they have very good data for their effectiveness and also their safety. So if you do come to clinic, these are things that we will talk to you about, okay. Other options for treatment include things like injection of urethral bulking agents as well as a Birch Couple suspension. Okay, so now I will quickly change gears because time is running out on us very rapidly. All right, so we'll talk a little bit about urgency incontinence as well as overactive bladder. Okay, so this is a situation where there's an overwhelming urge to pass urine immediately before or accompanied by leakage. Okay, so this is also concurrently happens with frequency of urination and nocturia, which is waking up at night for the purpose of peeing. Okay, and this happens when there is uncontrolled bladder muscle contractions and happens more commonly in older women. So again, what happens in clinic? Okay, oops. So you will, yes, need to speak to us and we will get through the whole history just like in SUI, okay? We will also perform a body check, all right, to exclude any other causes or any other diagnosis which may actually blur or confuse the situation, all right? You will need to undergo some additional urine tests, okay? And you may be also asked to fill in a bladder diary to look at your fluid intake, means how much you drink and how much you pee, okay, and also what you drink and and what time you do all the drinking and peeing. And this will help us to better analyze the situation and give you suggestions as to how we can improve the situation. Okay, so some of the patients, some of us may recommend you to undergo a bladder function computerized testing called urodynamic study, but this is not always compulsory for every patient prior to starting treatment. So the treatment for overactive bladder in a nutshell, okay, is basically always we will definitely start with lifestyle and behavioral changes, okay. So the things that trigger off overactive bladder, which are quite established, include everything in the top left, in the left-hand side of my pictures there, okay, which is caffeinated stuff, coffee, tea, spicy, acidic foods, and alcohol. Okay, so if you just remember this picture, you remember not to take the stuff in this picture, it may already help your symptoms. Okay, and then we also will recommend patients to undergo bladder training, which is not the same as Kegel exercises, and I will quickly talk a little bit about it after this. Okay, if the initial lifestyle behavioral changes as well as bladder training is not effective for you, or it only gives you partial relief without giving you very good effect, then we may consider starting some medications with you, which are the stuff that are shown on the right-hand side of my slides picture. Okay, and there are two different main families of medications, which are the antimuscarinic medications and the beta-3 adrenergic agonists. And sometimes patients who have more significant or severe symptoms may require a combination therapy. Okay. Then there are also some other third-line therapies, such as injection of Botox into the bladder or nerve stimulation, which we only do after a very detailed discussion and after not having successful results with initial treatment. Okay, so as mentioned, we talk a little bit about bladder training because people often confuse bladder training with pelvic floor exercises. They are really not the same, okay? And bladder training, we will actually also done by our specialized pelvic floor physiotherapists, but they will actually concentrate more on things like urge deferment, on forced urge, okay? So if you do feel mild urge at less than 1 hour, you're actually advised to defer it for a while, delay it for a while before running to the toilet, okay? And stuff that you can do to do that would be to apply some perineum pressure, to perform deep breathing exercises, to slowly walk to the toilet instead of running there, okay, which is a bit contradictory to what you normally would imagine wanting to do, and also distracting yourself, either counting your footsteps, watching some YouTube short video or something like that as you make your way to toilet, okay, so that will all be methods of urge deferment. And also too, we actually encourage to reduce the let me pee just in case kind of action, which a lot of us we know will always do, okay, before going out, before going on long travels and stuff like that. So to always avoid with a moderate urge when you have a heavy sensation at the bladder, and to ideally aim for more than 1 hour for intervals. So all these are techniques of bladder training to recalibrate the bladder to relax itself, okay, and not keep wanting to go to the toilet. All right, so this can be done in addition to also Kegel's exercises, okay, but they are in essence separate things. Then when we talk about medications, like I mentioned, there are the two main families there, okay? So some of these terms you may or may not be familiar with if you have already been treated before, okay? Such as the antimuscarinics, we use sulfaphanocin and totaradine. They come with different trade names, okay? But they do have the side effects of dry eyes, dry mouth, constipation, okay? And there is also potential negative impact on cognition, okay? So especially for the older generation medications like the oxybutynin, okay? And they also cannot be given in patients who have narrow angle closure glaucoma, okay, myasthenia and gastric retention problems. So these are these are things that we'll ask you and screen and discuss with you before we actually consider starting meds in clinic, okay? And the other one, which is the beta-3 adrenergic, has caused side effects of things like headache, runny nose, and stomach upset, okay? And it cannot be given in patients who have severely uncontrolled high blood pressure of more than 180 over 110, okay? And we would always need to monitor the blood pressure, not just before starting therapy, but home monitoring during therapy and at every appointment when you come to see us, okay? It's also a little bit more costly than the antimuscarinic family of medications. So with regards to medications, the principles of prescribing, okay, what we will always do is that we will start with the lowest dose single medication that is effective, and then we will assess in about 6 weeks or so, okay, and we will need and make modifications in terms of dose increment or additional adding other medicines like combination therapy as required, okay. And we should note that the positive effects on the urinary problems, okay, means that the benefits on the urinary problems and the side effects, for example, the dry eyes, dry mouth, constipation, tend to come together, okay. So we will always do an assessment of the treatment effects after about 6 weeks of starting the treatment, all right. And we also have to look out for urinary retention because this is a known problem that can happen after starting some anti-muscarinic medications for OAB. Okay, so just to put in a very quick slide here, to say that whilst we have talked a lot about the various treatment options, okay, and how to eradicate this problem of urinary incontinence, but in a practical sense of things, for some patients, due to various underlying factors, you may not be able to completely exclude or live without incontinence. So in that case, in that situation, then at least we want to live with incontinence in a safe and dignified manner. Okay, so we want to, when we use the adjuncts or the things to help with managing incontinence, we also should do the correct things for it. So, for example, a lot of us say we will use a pad, to absorb the leaking urine when they have a cough or sneeze or when they're very urgent. Okay, but actually, not all pads are the same because I do have many patients telling me that they are wearing menstrual pads, but they are actually incontinence pads that are specifically designed to be able to absorb urine better, and those are not menstrual pads. So one should be able to differentiate the two different things. Okay, so if you are amongst the audience is one of those people who actually don't know the difference that there is such thing called an incontinence pads, then I recommend you to go into any NTUC or pharmacy later on today and take a look because they are different and the effectiveness of an incontinence pads obviously would be better for incontinence than that of a menstrual pad, and that may reduce the leaking episodes, reduce the side effects like having a so-called nappy rash with the urine keep on exposed to your skin. Okay, and then of course there are also some incontinence so-called tampons like the picture on the left hand side, which also helps to absorb urine for patients who want to try out. These are also available. Okay, and then we have toileting aids, especially for the elderly who may be experiencing urgency and may find it difficult or dangerous to go to the toilet, which may not be very near them all the time. You can even buy a portable toilet just like that, and put it in their rooms or set up, railings in the toilet, make sure the toilet and the floors are properly lighted so that if they were to go up, if they have to wake up at night to go to the toilet, they will not end up falling and having more new problems added to what is already a problem. So these are things that we can do that to help live with incontinence if really we have to live with it. Okay, and just last few slides, there's a little bit of a spotlight about talking about incomplete urination after giving birth, because obviously our population today, our audience today, we have all kinds of people who may be younger, who may have just given birth, who may be pregnant, or who may have family members who are currently pregnant. Okay, so this is actually a problem which is increasingly being recognized because it was previously not noted. All right, and it's actually more common than we think, where you cannot pee properly after giving birth. This happens to up to 1 in 4 women. Okay, and can happen to any woman who undergoes delivery, even though the so-called risk factors or the people who are more at risk of having these problems are those who have had an epidural, for example, or prolonged labor, or who have had an instrumental delivery, had an episiotomy, or who are having their first baby. Okay, why is this an issue? All right, is because if you do not recognize it and it is not picked up and treated, this can result in a long-term need for insertion of urine tube right after giving birth, and it can result in a long-term or in rare and unfortunate situations, permanent problems with passing urine completely for the lifetime. And some patients even need to drain their urine a couple of days themselves because they otherwise can't pee properly. Okay, so what can you do, all right, if you are in this situation, or if you are going to give birth or you've just given birth, is to think about what we call the VESI questions. Okay, so the VESI questions are basically, did you pass a good volume? Did your bladder feel empty at the end of peeing? Do you have a sensation that you still want to pass urine even though you have just peed? Was your urinary stream normal? And was there any incontinence or leaking of urine, when you're carrying out your daily activities? If your answer is as such to all of the above questions or any of the above questions, you may be at a risk of having incomplete urination after giving birth, and this should then trigger you to ask for help. Okay, asking for help can be anything from talking to your obstetrician, or if you're still in the ward, from informing the nurses and the doctors in the ward that there's the situation, so that more attention can be paid to you and to discover whether this is truly affecting you or not. Okay, so as a conclusion, all right, I would say that, in order for us to be able to manage and treat urinary incontinence, first and foremost, we must prevent. So do the stuff that can reduce the risk factors to help your own situation. And the next thing, of course, is to identify the problem and identify it early and to seek help. Okay, so seek help would start from going to your family doctors, going to the polyclinic, telling people that you have this problem. Seek help can even start by telling your family members that you have this problem, so that your family members can help you to escalate the issue and to seek medical help. Okay, and then once this problem is identified, then we can deal with the treatment part. And obviously, we all know the earlier you treat, the better the outcomes will always be. And with that, we can manage urinary incontinence, ideally treat it, but if not, live very, very well with the remnant little bit of incontinence that may be there. Okay, so I thank you all again for the attention. Now I talk about urinary incontinence, and I will hand the mic back to Inru, who will introduce our next speaker. Thank you very much.
Thank you, Dr. Lee, for your comprehensive talk on urinary incontinence. Our next speaker is Clinical Assistant Professor Park Jun Jae. He's a senior consultant in the Department of Urology at Changi General Hospital and the SingHealth Duke-NUS Pelvic Floor Disorders Center. He's an expert in managing various urological conditions and has a special interest in research, innovation, and education. Dr. Park will be speaking about a very important topic of recurrent urinary tract infections and simple steps to break the cycle. Dr. Park, please.
Good morning, everybody. Thank you for that kind introduction, and thank you for the previous speakers for such a nice comprehensive talk. I hope everybody can hear me, and my talk will be about what to do if you have frequent urinary tract infections, or technically what will be recurrent urinary tract infections, and the simple steps that you could potentially take to break the cycle. Today, I'll be talking about understanding what is a urinary tract infection, or UTI, the different types of UTI, as well as simple steps to break the cycle. So, first of all, let's just understand a bit about what a UTI is. First thing is a bit of anatomy. Women and men have different anatomy. The important part is that you have a bladder and you have a urethra. And the urethra in women are just considerably shorter than in male, which is one of the reasons why UTIs are commoner in women. The human bladder only has two functions. One is to store the urine nice and safely. You keep it there, and actually the bladder is surprisingly quite complex, where it keeps the urine at a safe pressure in the bladder. Then when it's time to pee, then you empty that urine, and it's convenient to oneself, and when it's socially acceptable. And this is all very well coordinated, where the bladder contracts and the sphincters opens up, and you're able to empty the bladder completely or near completely. About 99% of the bladder is in this storage mode. And it's not a passive mode, but it's a constantly, a lot of things happening in your bladder when that is going on. The bladder fills up and constantly relaxes, able to detect, and it's all this done in autopilot, which makes the urine in the bladder a very good petri dish. It's in normal circumstances, the urine, generally there is no bacteria, is nice and sterile, and everything is quite nice in there. But it also, if bacteria eventually gets into the bladder, it depends. Sometimes bacteria are just there swimming around, not doing anything to you. And it's surprisingly quite common in the elderly to just have bacteria in the urine, but not causing any infection. But if that bacteria penetrates the wall of the bladder, it may cause inflammation and infections and so-called UTI. So the bladder is a surprisingly nice environment for the bacteria to thrive if you let them. Let me introduce you to Mr. E. coli. Okay, this is a very common bacteria, and about half of all UTIs are caused by E. coli. And therefore, by far the most studied bacteria in patients with UTIs. Other common bacteria are Klebsiella and Proteus. So in this this drawing that I got online, you can see this bacteria, and it has this long arm called flagella to help them to move around. But it has this kind of smaller arms or hair-like structures called pili, pilus for single, pili for plural. And you can see in this microscope, you see these hair-like structures. And these are the structures which leads to adherence to the bladder wall. You can see here that E. coli is actually part of our normal gut. I have it, you have it, we all have it. It's in the gut, it's in our stools, and they are just fine there so long they stay there. But if the bacteria somehow is able to go in and enter the bladder through the urethra, and then is able to adhere to the bladder wall through this pilus that I told you about just now, and is able to successfully enter the wall of the bladder. Actually, most of it will be kicked out of the bladder, but sometimes they are quite persistent and they enter the bladder, and then it can cause an inflammation, and your white cells, your body immune system will try to attack it. But in that process, you will feel the symptoms of UTI. So what is, let me just talk to you about what a straightforward uncomplicated UTI is and how that differs from a complicated UTI. And so an uncomplicated UTI, let me just explain to you, when somebody has a UTI, they usually complain of a burning sensation when they pass urine at the tip of their urine passage. Usually it's associated with, therefore, going to the toilet very frequently. They have this urgency associated with this. And they may even see some blood in the urine, although not so common. And even the blood may be more like a tinge Ribena color rather than full blood. And it's associated with this lower tummy pain. As you can imagine, it's very miserable to have UTI, and it's something that will affect your quality of life and your ability to walk properly. And fortunately, if you happen to live hundreds of years ago, there is no antibiotics. And actually, most people will just recover. It will take about 5 days of misery, 7 days of misery, and then eventually will disappear, even without antibiotics. But if you take antibiotics, then you will shorten that miserable recovery time significantly shorter. And an uncomplicated UTI is something that happens in a healthy adult female, okay? It's therefore non-menopausal, you're still having your menses, you're not pregnant, you don't have any fever, it's all localized down there, and you don't actually have any underlying conditions such as a structural abnormality or conditions that may predispose you to having UTI like diabetes. And so this is what we call a uncomplicated UTI, also known as simple cystitis. And so this is very common. So a complicated UTI is basically the same symptoms, but it happens in women who are postmenopausal, so you no longer have menses. You happen to be pregnant at the time of your UTI. You may have fever, may not, but you may have fever. You have underlying conditions. So if you fall outside of the norm of a simple, straightforward female of childbearing age without being pregnant, that would be what we call a simple UTI. But we call it complicated when you have any of these other additional ones. There's other long list of other things that will classify as complicated UTI, but these are some of them. Okay? UTI themselves are very common. Okay? 1/3 of all women by the age of 24 will have had a UTI already. And in your lifetime, 50% of women have had at least one UTI in their lifetime. Which is not the case for men. Men having UTI, especially in the younger years, is actually very rare. The incidence of UTI gets a bit commoner as they grow older, as they have prostate issues. But even there is nowhere near how commonly the women have in comparison. What are risk factors? What are you more likely to have a UTI? If you are sexually active, sexual intercourse is actually a risk factor for UTI. The vagina opening is very close to the urethra. And so there is this term of, in the olden days where sex before marriage was uncommon. So during their honeymoon, when they first time have intercourse, they have a UTI. So classically they will call honeymoon cystitis, where the whole honeymoon was ruined because soon after starting the honeymoon, they have the intercourse for the first time and then the whole honeymoon gets ruined. Use of spermicides, which fortunately is not so common nowadays. A lot of the even contraceptives like condoms no longer put spermicide in it, but some people may still want to, but it's a known risk factors. If you have a new sexual partner, suddenly that somehow changes things. And then if you have a family history, if you have a mother with a history of UTI, then you're more likely to have a UTI yourself. If you happen to have, for some reason, a UTI during childhood, then you're more likely to have it as an adult. So now that you know what a UTI is, whether it's a simple, straightforward, uncomplicated UTI or in the context of a complicated UTI, either way, if you have it very frequently, then we call that recurrent UTIs. It has a definition, is when you have it 3 times in a given year, in a 12-month period, or in the last 6 months, you had it 2 times already, then it's called a recurrent UTI. The strange thing, if it does mean that if you had maybe 1 UTI in a year, you are considered normal, okay? So it's surprisingly quite common. You have a UTI once a year, with or without antibiotic, you recover, that's kind of considered normal. But this kind of strict 3 times UTI per year, 2 times UTI per 6 months is more for research purposes and just to have a black and white definition. Of course, if you have it once a year, that's also not pleasant. It kind of ruins that week for once a year. And so it's something that you can do something about it. And this talk will be relevant to you too. So let's talk about things that you may be able to do, okay? One is behavior modification advice is increasing fluid intake. In Singapore, particularly many countries around Asia, fluid intake is generally on the low side. On average, it will be about 1 liter or less than 1.5 liter per day will be the average intake. And actually, the majority of women who drinks very little water, they don't get UTI, and you see those people. But if you do happen to have a lot of UTIs, frequent UTIs, then you should aim to increase your fluid intake to about 2 and 2.5 liters per day. Be a bit cautious of drinking any more than that, because then, as our previous speaker said, you may end up having urgency of going to the toilet very often, and that may affect your quality of life. So be careful not to overdo it. Sometimes when I tell my patients, drink more water, some of them, they say, yes, doctor, and then they end up drinking 4 or 5 liters. I think my record patient drinks 6 liters in a day, and that wasn't very good. So, you're kind of aiming for a healthy 2.5 liters per day. Of course, if you are like a marathon runner, you exercise a lot, you may even have to drink 3 liters, and that's fine. Other behavior modification is that after you have sex, after intercourse, you should try to pee. Even you should try before and after. And the reason being is that, as I explained to you earlier, the bladder being a nice environment for for bacteria growth, you're kind of trying to flush away any bacteria that has managed to enter your bladder through the urethra during the act of intercourse. So just having that habit of after intercourse, you don't fall to sleep, and then now your bladder becomes a nice petri dish for the next 6 hours while you sleep. You just get up, pee, and after you pee, at least you've done your best to flush away whatever bacteria, and then you go to sleep thereafter. That's a good habit to have. And another good habit to have is to, let me show you the other slide first. Okay, the other one is to avoid washing with soap to the vagina and the urethra, and avoid douching that area. Some women have this habit, and it's a bit counterintuitive. Oh, I'm gonna prevent having UTI. So after peeing or after sex, I'm gonna wash this area because there is something that I can do. Ironically, when you do that, you may actually kill the healthy, good bacteria that may be on your private area. And it's a bit of a problem of real estate. Per centimeter square real estate, there will always be good bacteria and there will always be bad bacteria. And whether you like it, you will always have it. No matter how much you wash it, there will always be bacteria there. It's not a sterile environment. That's the reality of life. But you want them to be more good bacteria so that they take more space. So the percentage of bad bacteria around that skin area and so on is minimized. But if you kill them with soap, you end up killing the good bacteria more, which are a bit more fragile to soap. And then there will be an overgrowth of bad bacteria. So same logic, in the gut, the reason that people recommend having probiotics and so on is that you want the per gram of stool to have more healthy bacteria than bad bacteria. So avoid using soap down there. It's okay if you wash your hair and your body and some soap goes down there, that's fine. And you can just use your hand just with water to wash down that area. But you should avoid, putting like soap and just rub down that area. It just potentially do more harm than good, potentially. The evidence for that is a bit poor because it's very hard to do this kind of studies where they get 1,000 women in one arm, 1,000 women in another, and you tell them what to do. It's actually a very difficult studies to do. The other one is to avoid using the douche and spraying down below because the act of spraying may push bacteria up the urethra into the bladder. It may not, but it's hard to, again, prove this, but generally no need to do that. And when I say this to patients who does this regularly, and I'm explaining this, they usually kind of frown a bit and it's like, really, man, that doesn't make sense. Until I tell them, well, if you think about it, your ancestors, wherever that may be in Ming Dynasty China or whatnot, if you think about it, they didn't really have soap and they didn't wash there. They just pee, and when they finish, they are done, and then they get up, and they were fine. And they'll go, that makes sense. And sometimes our modern habits can get in the way of what you're intended to do. Now, the other one is the wiping your backside after you pass motion. Interestingly, some patients, they like to wipe their backside, the anus, after they pass motions with this figure A, where they put the toilet paper in hand and they put it in between the leg in the front and they wipe the backside from that direction back to front, okay? And of course, some people, they will use the hand with the toilet paper, they kind of lean to a side, and then they will put the hand on their backside from the back, and then they will then wipe from front to back direction. It's a habit that some people have. And in this interesting Japanese study that I put down here, they found that 44% of these Japanese women in this study actually says that they will wipe their backside in that front to from back to front with hand in between the legs. Their study showed that in a certain subgroup analysis on some women that can increase the risk of urinary tract infection compared to the more putting the hand in the backside. You may be wondering why some people will do this and the other is habit. Some people is the ability to kind of lean to a side and have that kind of balance to do so due to body habitus or any other issue. It is just much easier to go from the hand between the legs. But this is what we mean by changing your wiping habit from front to back with the hand behind. So again, a lot of these studies with recurrent UTIs are very poor. It's very hard to say for sure. So I'm not going to nag at my patients for doing this. It's just an advice, something that you perhaps want to look into, just changing your habit to do so in the back if you have recurrent UTI, and that may help to you together with everything else that I've been saying or will be saying. The other behavior modification that is being advised is to change the underwear from occlusive to non-occlusive, so ultra tight versus slightly loose, more breathable underwear like cotton versus synthetics. Again, there are not that very super strong conclusive evidence. There are some evidence, don't get me wrong, but the quality of the evidence is not as robust. Just primarily, it's just so hard to make such a studies in recurrent UTI. But again, if you have not changed your underwear in years, has little holes already, you like your favorite underwear, but they are synthetic material, not very breathable, very tight, you might like to consider changing them to something looser, something made with cotton. Singapore is a very hot country. Whether you like it or not, you stand outside, you may get sweaty in no time. And that may increase the likelihood of bacteria overgrowth in that private area. So it's not a bad idea also to change your underwear a bit more frequently, twice a day, perhaps 3 times a day. That may or may not, again, I'm not going to be too dogmatic about this. Now, important thing though, and it's surprisingly quite common in Singapore, is diabetes, okay? You know, screen yourself for diabetes, particularly if you have risk factors like you have family history of diabetes, you have your BMI, your weight is quite high, then by all means do screen yourself for diabetes, because diabetes affects your immune system, your ability to fight infections well, and B, the excess sugar in your body can be dumped into the urine because the kidney cannot cope. And then that now you have a very good petri dish with sugar inside. So it can be even a better petri dish for growth of bacteria in your bladder. If you already have diabetes, please control it as best as you can to also help towards preventing UTI. This photo that I put here is from one of our clinics in Changi Hospital, and they put it there as an illustration how easy it is to consume sugar in the most benign looking drinks. Okay, the number of sugar cubes equivalent in a standard Coca-Cola is like 8 cubes. A single even 100 plus, that sounds very healthy. You can have 5 cubes of sugar. And some of the kind of Starbucks, fancy, especially Christmas is coming, special mocha and so on, can have a huge amount of sugar in there. So you, unfortunately or fortunately, Singapore boleh, food is nice, but you'll be surprised how sugary or the carbohydrate ultimately gets breaks down to sugar. So, really control your diabetes. If you have diabetes plus recurrent UTI, just controlling your diabetes very well can go really a long way on preventing UTIs. Also, though, there is this medication called in the family of SGLT2 inhibitors. There are 2 available in Singapore at the moment. It's called dapagliflozin or empagliflozin. Brand names are Forxiga and Jardiance. Okay, these 2 medications are very common nowadays. They are very good medication in controlling your sugars. and preventing all these long-term complications related to diabetes. But the way they work is that they will actually ask the kidneys to dump excess sugars into the urine. So as you can imagine, the risk of UTI when you take this medication is higher. And so if you already have or develop recurrent urinary tract infection and you're taking this medication, it will just not help. No doubt it's very helpful medication. You might have to talk to your doctor and consider stopping this medication if you have recurrent urinary tract infection. Something to discuss, something to pros and cons weigh the balance. Now, those are so far things that you could do by yourself. Once you are found to have recurrent UTI and your GP or polyclinic doctor has ascertained that you don't have any other underlying cause and you are simple recurrent UTI. Okay? But on top of that, if you keep having UTI or it makes you very miserable, then you can things that can be done is taking antibiotics. Post-intercourse, if you get particularly, it's very obvious to you, I'm fine so long I don't have sex. The moment I have sex, within a day or 2 or 3, I get a UTI. Very obvious, you know. Then my partner goes on business trip for a month. Then no sex, no UTI. It's very obvious. Then this kind of single low-dose antibiotic, for example, nitrofurantoin or cefalexin, single dose just after or just before sex can take care of that because there is not too much bacteria yet because he has entered the bladder. They have not yet multiplied. And before they multiply, the antibiotic kills them, and therefore it prevents you from having a UTI. It's an option to think about. The other one is that we give you a stock of antibiotics to take. Usually 3 days is enough. There are even some antibiotics that you can just take for a day. Just keep it at home, and then it's not, and then you don't get it very often, maybe once a year, twice a year, not very often. And then the moment that you get that initial urine symptoms, the urinary tract symptom, and then you just take the antibiotics, and then that will stop it from becoming really bad. So we call this a self-start regime. The other option, especially if you have it very often, like 3 times a year or more, no? Then it might be a good idea that at least for a period of time to break the cycle, to be in this low-dose daily antibiotic. And then the idea is that it will protect you from having a urine infection because you don't know when it's going to happen, but you know you get them very often. And you take them on a daily basis, giving a chance for the bladder to not have a UTI for a prolonged period of time. The rationale behind this is that there is a very invisible protein layer called a GAG layer, glycoprotein layer that forms. And the idea is that if you get very recurrent UTI, this layer doesn't have time to form, and it does take some time to form. So if you can break the cycle for 3 to 6 months, then you will have a chance to have this protective layer. And hopefully after 3 to 6 months, you can stop the low-dose prophylactic antibiotics and you will go back to kind of the baseline. Maybe once a year or once every 2 years, you get a UTI. Most studies doesn't go beyond 6 months. Some patients take it longer than 6 months, particularly if they're very anxious and particularly having tried for 6 months and then a few months later they get UTI again. They can be on it for years. But you know, all this should not be done with self-prescription. It should be done together with the help with your physician. There are some non-antibiotic-based treatment. You know, you Google search recurrent UTI, you'll get this gazillion of things that they will promise you the world. But if you look at the literature, if you take oral probiotics every day, mixed data. Generally speaking, I recommend it to my patient because it's very safe. It may even help the gut constipations and things like that, which I'm not going to talk about much because the next speaker will be talking about that. But in terms of hard evidence, I would just say it's kind of there. The same vein, cranberry. Cranberry has an active component that can prevent the bacteria from sticking to the bladder, particularly the E. coli, P. villi, I was mentioning earlier. But again, the quality of the evidence is a bit poor. A lot of them are very old studies, and a lot of them were kind of sponsored by the cranberry industry in the States. So, you know, you kind of have to take it with a pinch of salt, but it's very safe. You can drink cranberry, but you have to drink about 2 cups a day to be effective. So it's actually much more easier to buy the tablet version. What dose, exactly what dose, which brand, nobody really knows for sure. My advice is that you go to a Guardian because it's reputable rather than online. Mini, money more, just buy whichever cranberry tablet you think is more fancy looking or you can afford. But generally it costs about $1 a day. So 30 tablets will cost about $30. Any more than that, I'll just say don't waste your money. Don't buy the $100 for 30 tablets kind, very expensive. Just buy whichever you think and try it. Who knows? It's not so much the cranberry tablets because you end up drinking a cup of water with the tablets. So the evidence a little bit iffy, but safe. Okay, you can take it. There's this thing called D-NUS that has been studied as well, single randomized study. So therefore it gets a tick from me, but again, it's I won't be too dogmatic either. Estrogen, vaginal estrogen cream for those who have gone through menopause and they have menopause-related changes of the vagina. It may help. Again, the evidence is a little bit mixed. Some studies show that it helps, some studies that it doesn't in preventing UTI. And there's this other treatments which is a bit more invasive. You have to put a tube into the urethra, into the bladder, and you put this liquid to kind of help you to recreate this layer that I was telling you about. You know, it's a bit unpleasant to have a catheter put in, so I just put a question mark. And the strength of the evidence is a little bit mixed as well. There are a new generation of medications where it's vaccine. It's an oral vaccine. It's something that you take once a day for a few months, and it's teaching your immune system to fight off bacteria, particularly E. coli. They're very expensive. You take it for about, give or take 3 to 6 months, depending on the type. They're quite expensive. And unfortunately, at the moment in Singapore, it's not fully HSA registered. And therefore, most hospitals don't have this in their pharmacy, because if you really want it, then you have to make a special by name basis, ask the HSA for an exception for you. Part of the reason why it's so is that the evidence for this, although there is not ultra solid, and therefore and it's quite costly to register with the HSA. So again, by all means, it does help, but again, the evidence doesn't show that it's like 100% effective and so on, but it might be something that you might like to look into, especially if you are developing resistance to bacteria. So in conclusion, simple lifestyle changes may help. The one that I would probably encourage the most is to drink more water, because it's easier said than done. It's the evidence probably is the most reasonable evidence that there is there. Look into your wiping technique, how you wash down there, which I've talked about, something that you may have to look into it. At the same time, take it with a pinch of salt. No need to get too frustrated that having changed all these techniques, you seem to still getting UTI. Unfortunately, some women, even though they do everything that they can, they follow all this, they still get UTI, and that does happen. There's some women are just much more prone to getting UTI than others. And diabetes is the thing that I will strongly recommend for you to get screened and make sure that you don't have or look into the control of diabetes. Do seek help from your local doctor. As I said, screening for diabetes, control diabetes is important, but also make sure that you don't have any underlying cause where you may be having a recurrent UTI. Earlier, the speaker was talking about prolapse, which can also be a predisposing factor for UTI. You may have some undiagnosed bladder problem where the bladder doesn't empty properly, fully. Especially in the elderly, they can have bladder contractions that are weaker, and there's a lot of urine left over in the bladder, not fully emptying, constipation problem, and so on. So these are the kind of things that your physician will see you for, and make sure there is no other underlying condition. And they may need to refer you to a urologist or urogynecologist for further assessment or treatment. But a lot of the GPs and polyclinic can do that initial assessment, particularly if you are a very straightforward, simple, young female who gets UTI. They can give you the low-dose post-coital antibiotics. They can give you a self-start antibiotic regime. and they can give you low dose long-term antibiotics, having done the initial assessment and so on. And then we are always here as well to help. So thank you very much for your time, and I will give back the talk back to the team.
Thank you, Dr. Park. Our next speaker is Dr. Yvonne Ng. So Dr. Ng is a consultant colorectal surgeon at Singapore General Hospital and the SingHealth Duke-NUS Pelvic Floor Disorders Center. Dr. Ng completed her fellowship training in the UK in areas of robotic surgery for complex colorectal cancer and pelvic floor reconstruction. Dr. Ng will be giving us her talk on the common problem of constipation, and she'll be addressing common misconceptions about constipation. Dr. Ng, please.
Thank you, Dr. Tan. Hi, good morning and a warm welcome to everyone here today. My talk today will be on the common misconceptions about constipation. Constipation is a common problem that affects up to 20% of people every year. It's a difficult condition to define as bathroom habits vary considerably from person to person. The objective of my talk will be to address pervasive confusion and misinformation regarding constipation with a focus on diagnostic and therapeutic principles. So misconception 1, if you don't poop every day, you're constipated. Is this true or false? Well, what exactly defines constipation? Constipation is a problem with passing stool. It's hard to know whether or not our bowel movements are normal. How many times a day are we meant to go? Is it too much or not enough? You might worry that you're chronically constipated if you don't poop every day. But regular bowel movements is actually subjective and really depends on the individual person. Some people poo multiple times a day and others may move their bowels 3 times a week. So what's normal for one person might be unusual for someone else. So anyway, the symptoms of constipation are having less than 3 bowel movements a week, straining or having a hard time passing your stool, hard or lumpy stools, or feeling blocked or like you haven't passed all of your stool out, otherwise known as incomplete defecation. Myth 2. If I'm constipated, I must be unhealthy. So to answer this question, we must learn about the underlying causes that can result in constipation, and I will go through a few more common ones in this talk. In general, constipation occurs when stools move too slowly through the large intestine, also called the colon. If the stool moves slowly, the body absorbs too much water from the stool. The stool can become hard, dry, and difficult to pass. Causes, as seen in this slide, are multiple and can be multifactorial as well. So if the symptoms are persistent and bothersome, please consult a primary doctor who will take a thorough history and physical examination and start off with excluding lifestyle and dietary causes, medical comorbidities, or medication that may contribute to your constipation. If a suspicion of colorectal cancer is present, your primary doctor will refer you to a relevant specialist who may perform further investigations on you, such as a colonoscopy, to exclude worrisome causes like colorectal cancer. Thereafter, in a specialist setting, if your chronic constipation requires further management despite excluding colorectal cancer, further investigations may be pursued to diagnose a functional constipation secondary to a pelvic floor disorder, or finally, chronic idiopathic constipation, which is essentially chronic functional constipation without a known secondary cause. So constipation may occur when a person does not drink enough fluids, eat enough dietary fiber, exercise regularly. Regular exercise helps relieve and prevent constipation by stimulating intestinal muscles, increasing circulation, and improving the bowel muscle tone. Certain medical conditions may predispose to slow transit constipation due to its effects on the muscles, nerves, or hormones. This include endocrine or metabolic disorders such as diabetes or hyperthyroidism, neurologic disorders such as Parkinson's disease, psychiatric disorders such as depression or eating disorders, and constipation in pregnancy is also common due to hormonal shifts and mechanical pressure from the growing uterus. Medications such as opiates, anticholinergics, and antidepressants are also known to cause constipation. So as seen in this diagram, obviously if you have colorectal cancer, as demonstrated in the two endoscopic photographs, colorectal tumors cause an obvious mechanical obstruction. Hence, patients may experience constipation, especially in left-sided cancers where the stools are more formed. Now let's move on to the mid of the presentation, which is pelvic floor disorders, otherwise known as functional constipation. So after excluding the more common causes for patients with chronic constipation, we will want to find out if they have functional constipation secondary to a pelvic floor disorder, which may be correctable either via conservative management or surgery. The muscles that hold up the organs at the bottom of the torso are called the pelvic floor muscles. The ability both to relax these muscles and to bear down are necessary to pass through from the rectum. Patients with weakness or coordination of these muscles can cause chronic constipation. So pelvic floor weaknesses in a posterior compartment mainly manifest in two conditions. Firstly, in this slide, a rectal seal. As seen in the diagram, a rectal seal is defined as an outpouching of the rectal wall, and the rectal anterior wall is most commonly affected. They are common, and some degree of rectal seal formation is present in most symptomatic women. Rectal seals may develop due to weakness of the rectal vaginal fascia, promoted by different factors such as chronic constipation, complicated vaginal delivery, hysterectomy, congenital or constitutional weakness of the pelvic floor, or aging. A rectal seal does not necessarily impede evacuation, but retention of stool within a rectal seal may lead to a sense of incomplete evacuation. Pelvic floor weakness can also lead to outlet obstruction, which may also be caused by an intestinal rectal prolapse, otherwise known as intussusception. This is infolding of the rectal mucosal as demonstrated in the picture, and during defecation, and it can happen in the rectum or the anal canal. Patients may present with constipation or a feeling of incomplete evacuation as their main symptom due to outlet obstruction or with fecal incontinence. Specific investigations such as a defecating proctogram or MRI defecography can be utilized to demonstrate a rectal seal or rectal intussusception causing outlet obstruction. While constipation can be multifactorial, if a posterior compartment prolapse is deemed to be the primary reason for the patient's constipation symptoms, it may be amenable to targeted management with biofeedback therapy. Failing which, surgical options such as a posterior colpopharaphy, where the posterior vaginal wall muscles are reinforced, or a ventral mesh rectopexy, where the intussuscepting rectum is straightened as seen in the diagram, are options that can be explored with the patient. Now, the second group of pelvic floor disorders that we will discuss is what we call dyssynergic defecation. So dyssynergic defecation results in functional outlet obstruction during defecation and is one of the common causes of chronic constipation. It is characterized by either paradoxical contraction or an inability to relax the anal sphincter and or puborectalis muscle. At rest, the pelvic floor muscles and internal sphincter muscles are contracted to avoid leakage or incontinence, as seen in the diagram where there's normal defecation. During normal defecation, our diaphragm, abdominal and rectal muscles are contracted, whilst the anal sphincter and puborectalis, which is a pelvic floor muscle, are supposed to relax to allow for defecation to happen. However, in patients with dyssynergic defecation, there's discoordination where during defecation, there is instead a paradoxical increase in sphincter pressure, resulting in less than a 20% relaxation of the resting anal pressure, and there may be inadequate abdominal rectal propulsive forces, hence resulting in what the patient deems as constipation. So symptoms varies, but they are all centering on constipation, including rectal evacuation difficulties such as excessive straining, a sensation of blockage, a feeling of incomplete evacuation, with some patients even needing to have manually assisted defecation, and frequent use of enemas or suppositories. The exact cause of dyssynergic defecation is still unclear, but there seems to be an association between it and previous pelvic surgery, previous sexual abuse, anxiety, and psychological stress in some patients. Diagnosis can be made from history, physical, and special investigations, and management is largely conservative and may include retraining with anal-rectal biofeedback therapy. Now, constipation can also be a result of what we call slow transit constipation, which is defined as a prolongation of transit time through the colon. Causes of STC are multifactorial and can include medical conditions, pharmacological agents, and lifestyle factors such as dietary, a repressed urge to defecate, or inactivity. So what do we do if we suspect that a patient has slow transit constipation? We can confirm this with an imaging study known as the colonic transit study, otherwise known as a SIT study marker, which is performed to confirm this. So normal colonic transit time is usually 20 to 48 hours, and most adults will clear all markers in 4 to 5 days. So a patient is usually given about 20 markers to ingest, and on the 5th day, an X-ray is taken. So if more than 50% of the original rings are still present in the colon as per the diagram on the slide's right-hand corner, then this may be an indication that the patient has slow transit constipation. So again, in a pictorial form, normal transit is where the stools are passing normally. In slow transit, we realize that the stools are not passing within the normal colonic transit time to the rectum. And in this synergic defecation, there's a buildup of stools because the patient has an inability to bear down properly and defecate. So the management of slow transit constipation can be divided into lifestyle and dietary changes such as increasing fiber and fluids, exercising, and a healthy diet. Laxatives or prokinetic agents, or even enemas can be used to flush out the rectum when there is a significant buildup of feces. And other treatment modalities such as biofeedback or sacral nerve stimulation and/or surgery can be discussed if the first two options fail to improve the patient's condition. So now that we have gone through the various conditions that can contribute to constipation, let's clear up some misconceptions on the modifiable risk factors that we can utilize to improve constipation. So myth 3, all fiber are equal, true or false? Increasing fiber intake is an almost universal recommendation for chronic idiopathic constipation. You may have heard conflicting things about certain fruits like bananas. Some people say that bananas are good for constipation, while other people recommend using them to treat diarrhea, which suggests that they have the opposite effect. This is because not all fiber are equal, and their effectiveness in helping constipation is related to their fermentability and solubility characteristics. So dietary fiber is the name given to the non-digestible carbohydrate in plants. It can be found in all plant foods, including fruits, vegetables, greens, nuts, and seeds. It is usually characterized into two groups based on solubility. Insoluble fiber bulks up your stool and acts like a brush, sweeping through your bowels to get everything out and keep things going. The soluble variety absorbs water and forms a gel-like substance. This helps your stool pass smoothly through your bowels and improves its form and consistency. Most fiber-rich foods contain a mixture of insoluble and soluble fiber in varying proportions, whereas some dietary fibers, example prunes, contain sugar alcohols that exert an osmotic load to the colon to promote laxation irrespective of fiber content. So how fiber works for constipation? Long-chain carbohydrates have diverse characteristics related to fermentability and solubility, but only two forms of fiber help with constipation. One, poorly fermentable, insoluble fibers help to promote laxation through mechanical stimulation of fluid and mucous secretion, whereas non-fermentable soluble fibers result in a viscous gel matrix that retains water and resists dehydration, and this is usually the most appropriate initial choice for patients. Then we talk about why certain fibers can worsen constipation. Short-chain carbohydrates are both soluble and highly fermentable. So instead of helping with constipation, they lead to an increased gas production and therefore a negligible effect on constipation. And some patients may even think that this worsens their constipations. So do bananas cause constipation? It really depends on the type of banana that you're taking. Ripe bananas contain soluble fiber, which, when it dissolves in water in your digestive tract, forms a gel which acts like a natural stool softener and makes it easier to poo. Unripe green bananas, on the other hand, contain higher number of tannins and resistant starches, which can aggravate existing stubborn stools or constipation symptoms. A lack of water, when you increase your fiber intake without drinking enough water, the fiber can become hard and difficult to pass, potentially causing constipation and discomfort as well. Some people swear that their morning coffee helps move their bowels, but how true is that actually? So how does coffee help with constipation? It stimulates colon motility. Coffee, both caffeinated and decaffeinated, can help with constipation by stimulating muscle contractions in the colon that moves stool along, a process known as increased colon motility. It also releases gastrin. Components of coffee, including furan, trigger the release of gastrin, a hormone that increases the motility in the gut. The warmth and vasodilation of a warm coffee can also reduce resistance and increase the speed at which material passes through the digestive system. And lastly, a gastrocolic reflex. Coffee can enhance this natural reflex, which is a heightened response of the colon after a meal or a drink, particularly pronounced in the morning, leading to the urge to have a bowel movement. However, its effects really varies between individuals. And lastly, constipation while pregnant is both common and uncomfortable. It can be hard to tell which medication you can and can't take while pregnant and naturally be feeling more cautious than usual. So I thought I'll just go through some safe options for pregnancy constipation. So if you're pregnant, and you can try to treat your constipation first without taking any medicine, and this is ideal. This involves eating more fiber and drinking plenty of fluids. It may also help to do gentle exercise. If diet and lifestyle changes do not work, your doctor or midwife may recommend a laxative. So preferred first life options include bulk forming laxatives. This increases the bulk of your stools, making them easier to pass. Saline laxatives also work by drawing water into the bowel to soften stools. And lastly, osmotic laxatives are also non-absorbable and draw water into the bowel to soften stools. So these are some safe options that you can choose if you have pregnancy-associated constipation. Thank you so much for listening in. I hope you've obtained a better understanding of constipation, and I thank you for your kind attention.
Thank you, Dr. Ng. Last but not least, we have Ms. Hui Shu En. Shu En is a physiotherapist at the Singapore General Hospital with a special interest in pelvic health. She supports women across life stages from pregnancy to menopause and manages conditions such as incontinence and recovery after childbirth. Shu En will be giving us her talk entitled Pelvic Floor Exercises, Do's and Don'ts.
Thank you, Dr. Ingru, for the kind introduction. So Dr. Jill and Dr. Lee and the previous speakers have talked about doing pelvic floor exercises to help to manage pelvic floor dysfunction during their sharing. So now let's have a deeper look into how we can then do these exercises. So before we go into this, let's just have a quick recap of what this group of muscles do. We can have a look at this video from the Continence Foundation of Australia. So these muscles are a sling of muscles that span from the pubic bone at the front all the way to the tailbone at the back. They help to maintain the control of the bladder and the bowel, and they also allow the passage of urine and stools out of the body. They are also important in supporting the pelvic organs, which include the bladder, uterus, and the bowel. They are also involved in sexual function. Have you happened to come across advertisements or videos of people teaching such exercises and saying they are pelvic floor exercises? Well, just because these exercises work around the pelvis area does not necessarily mean that they are the pelvic floor exercises. These exercises in the photos here actually help to strengthen the hip, back, and abdominal muscles, which can help you perform your daily activities better, help you manage the weights that you need to carry at any point, and reduce the direct strain on the pelvic floor muscles alone. But they are not exactly the same as the pelvic floor muscles that are specifically required for you to have better bladder and bowel control. Have you also happened to come across such advertisements that sell products claiming to strengthen the pelvic floor muscles? So this device here actually seems to work more of the inner thigh muscles, but not exactly the pelvic floor muscles directly. So if we are just doing them, we might not really be seeing very big improvements in the control of the bladder and bowel. So then how are we supposed to do the exercises then? So let's have a look at this video. To better visualize these pelvic floor muscles, we can have a look at the video shown here. So to first find these muscles, you can imagine as if you're trying to stop the flow of the urine, or imagine trying to hold in some wind. Another way to think about it is imagine you're sitting on a marble, trying to pick up the marble with your bottom and lifting it up. When you're doing this exercise, you should feel a squeeze and a lifting movement. Once you have then identified this group of muscles, we can then start by choosing the position that you can feel this contraction best in. It could be when you're lying down on your side or your back, or when you're sitting or even standing. Then you can start to tighten and relax this muscle with good technique. You can aim to work towards 10 contractions in a set. Once you're able to do these 10 contractions with good technique, you can then progress to the more difficult version that involves some holding. For example, you could maybe start from about 2 counts, 5 repetitions with good technique. When you feel like that's manageable, you can slowly increase the duration of the holding to about 10 seconds, reaching 10 repetitions in a set. But it might take some weeks to months for you to get there, so be patient. What are some things that we should take note when we are trying to do these pelvic floor exercises? Firstly, it's very important to make sure that you're breathing normally. You should still be able to talk if you need to. It's also important to make sure you're relaxing the muscle fully after its contraction. If you don't release the contractions fully, you can actually overwork and over-tighten these muscles. It could lead to, for example, discomfort, fatigue, and even discomfort in the longer term. It is also encouraged to progress the exercises as you get better at them. So you can actually change up any of these at the following at a time. For example, you can vary the position that you practice them in. For a start, lying down might be a simple position for you to isolate the muscle and activate them well. When you feel like you get better control, you can consider to try them when you're sitting, where some gravity is acting on the muscle, so it might be a little bit more of a challenge compared to lying down. You can then also progress them when you're standing or eventually when you're walking. You can also consider to reduce the rest duration that you're taking in between each repetition. You can also increase the number of repetitions and sets you're doing, aiming for about 8 to 10 repetitions, 3 sets a day. We also encourage you to tighten these pelvic floor muscles before activities such as the cough, sneeze, and lifting, which are activities that can cause leaking in people with stress urinary incontinence. So sometimes what happens is that with these activities, these involve a contraction of the abdominal muscles and the diaphragm, which can then increase the pressure within the abdominal cavity, and that can act downwards on the pelvic floor muscles. If the pelvic floor muscles are not able to work in time, or they're not strong enough to maintain against that increased pressure, some urinary leakage can happen. So what we can do is to tighten the pelvic floor before those movements to help reduce the risk of leakage. We also encourage you to be consistent and persist with the exercise. You may take about 4 to 6 weeks to start seeing some improvements in the symptoms, and the muscles can take up to 3 to 6 months to be fully strengthened for you to see more significant changes in your symptoms. As with any type of exercise, consistency is very important for improvements to be seen, and your pelvic floor muscle exercises are no exception. Setting aside a regular time for your exercises can make it more likely for you to keep up with the routine. So now that we kind of understand how to do these exercises, there are some things that we need to take note of not to be doing as well. We want to be doing them correctly so that we are maximizing the improvements and benefit from them. First thing we'll encourage is not to squeeze the wrong group of muscles. It's important to make sure you're not tensing your tummy, inner thighs, or buttocks. When you're doing that, it can actually increase the pressure within the abdominal area, and it can actually cause some downward pressure on the pelvic floor. Sometimes these wrong techniques can actually worsen the leakage instead. So one way to check when you're doing these exercises is you could perhaps put your hand on your tummy or on your inner thighs to feel. They should still remain quite soft and relaxed. The pelvic floor should be able to be isolated and contracted while the rest of the body remains relaxed. It is also important to make sure that you're not holding your breath when you're doing this exercise. When you're holding your breath, there's a downward movement of the diaphragm, which can then increase the pressure within the abdominal cavity and can also cause a downward pressure on these pelvic floor muscles. This can end up causing the muscles to go in the opposite direction that you want them to be going. So ideally, when you're doing the pelvic floor exercises, there shouldn't be any significant change in your breathing pattern. It is also important to make sure that you're not straining or bearing down when you're doing this pelvic floor exercise. It shouldn't feel as if you're trying to have a bowel movement when you're doing this exercise, as these can actually increase the pressure within the abdominal area. It can also weaken your pelvic floor muscles, which is exactly the opposite of what we are trying to achieve here. So when you're doing the exercise, you should feel like a tightening and lifting kind of movement, similar to the sensation of trying to stop your urine halfway or trying to hold in some wind. It's also important that you don't practice these exercises when you're actually passing urine. So while stopping the flow of the urine can be one way to help you identify this group of muscles, it should never be used as a regular pelvic floor exercise, because it can increase the risk of incomplete emptying of the bladder, which can then increase the risk of you getting a urinary tract infection. So if, let's say, when you're doing the exercise, you notice you're having some pain or discomfort, we also will recommend that you stop and maybe speak to your doctor or pelvic health physiotherapist for further evaluation. I also like to take this chance to address some common misconceptions that I think some of the speakers before might have already addressed. So a common misconception that some people might have is that it's normal to be leaking urine during pregnancy and or after childbirth. So while it is quite common for many women to be experiencing these symptoms during pregnancy and especially after delivery, it is not necessarily normal. And in fact, having some urinary incontinence during pregnancy is a strong predictor of developing pelvic floor disorders 12 years post-delivery, as found in some studies. And something can definitely be done. Another common misconception is that just because you're planning for a cesarean section for delivery, thinking that the pelvic floor is completely safe. Well, as Dr. Jill mentioned earlier, vaginal delivery is not the only risk factor for developing pelvic floor muscle dysfunction after delivery. Pregnancy itself can already carry a risk of pelvic floor muscle changes due to the hormone changes that can happen and the effect that they have on the connective tissue. All these other different factors can actually influence the risk of getting incontinence after delivery. So this can include things like increased maternal age of 35 years and above, having more deliveries, heavier baby weight, delivering twins, triplets, or even having a history of urinary incontinence previously. So the extra weight of the baby acting on the pelvic floor muscles during pregnancy could already be enough for some women to be symptomatic, regardless of the eventual mode of delivery. Another common misconception is that the pelvic floor exercises are only meant for mothers, or if, let's say, you're too old, already postmenopausal, it's too late to get started. As Dr. Jill mentioned during her sharing earlier, 1 in 2 women actually present with urinary incontinence across their life, and these issues can affect women across all life stages. There are other risk factors that can also increase the risk of you getting a pelvic floor muscle dysfunction. So this can include things like obesity, chronic constipation, straining, and coughing, which the previous speakers have also mentioned as well. So we strongly encourage all women to be doing their pelvic floor exercises, even if they have not given birth. All muscles should be exercised regularly, not just the muscles that you can see. And it's of course never too old to start, so it's something that it can be done and should be done regularly across the lifespan. Some people might also say that, oh, maybe they have other medical conditions like joint problems and have no time to do this exercise. Actually, in fact, the good news is that the pelvic floor muscle exercises don't actually require any specific special equipment, clothing, or even sport shoes. And these are activities that can be easily incorporated into your daily routine once you have found the right group of muscles and how to activate them. It can be done when you're driving, when you're waiting for the kettle to boil, when you're watching TV, or even chatting on the phone. So it is something that really can be done anytime and anywhere. Some people might also say that they have tried the pelvic floor exercises, but they don't seem to be working. And our question is this: are you doing them correctly? And are you doing enough? So you do need to have a specific exercise kind of regime and routine to get the muscles stronger. Some might also say that when they try to hold their bladder, their muscles are already getting a workout. Well, if you're having some form of like leakage or pelvic floor muscle problems, or if you wish to prevent them, it is better to keep the pelvic floor muscles toned with a specific exercise regime, rather than hoping that any incidental activity will be sufficient. A more structured program with appropriate intensity and progression is very important to get a muscle stronger than they already are. So then just to end off, these are some signs that you might want to take note of when to seek help. If you tried these exercises with the different tips that are given, but you find that you can't really activate this right group of muscles, or if you feel like you're not sure whether you're doing them correctly, or if you feel like you've been doing them very consistently for at least 3 months, but you don't see any improvement in your symptoms, or if in fact after doing them you feel like your symptoms seem to be worsening, like in terms of you feel more leakage or you feel more heaviness, we strongly encourage you to consult your doctor and consider asking for a referral to a pelvic health physiotherapist. We can then guide and assess you and suggest what is a better way that can move forward. And with that, thank you.
Okay, thank you, Ms. Wei, for her practical tips on pelvic floor exercises. So we now have some time for a short Q&A session. There are many interesting questions on the chat board, and I think our panelists have tried to address many of the questions. So there is a question posted on whether recurrent UTIs have any long-term complications. For example, can it lead to cancer? May I invite Dr. Park to address this question?
Hello. By the way, earlier there was some questions, but I've been having some issue with connection. So if I didn't answer, wasn't on purpose. Apologies. So the questions whether recurrent UTI can increase your risk of cancer. The short answer is no. Having said that, if you have quite bad recurrent UTI and so on, then you should get a assessment, because one rather uncommon rare cause of UTI is having an undiagnosed cancer, particularly of the bladder. So things like that is checked by urine tests as well as some scans if necessary. And some patients, they may even need a cystoscope, which is a camera that goes into the urethra to look into the bladder. But just having recurrent UTI doesn't increase your risk of infection. A very specific type of infection, which is rare in Singapore, called schistosomiasis, that occurs mainly in some Mediterranean countries like in Egypt, that can increase the risk of bladder cancer, but not in infection itself.
Thank you, Dr. Park. There is also another interesting question about chronic constipation. So, how does chronic constipation affect pelvic health? And if someone has chronic constipation, what can they do to cure this issue if they've been having it for many years? For this question, maybe I can invite Dr. Ng to share her experience.
Okay, thank you. So as mentioned, if you are experiencing chronic constipation, especially in the age group of more than 50 years old, we would advise that you seek a medical opinion, see a medical doctor who would then take a thorough history and physical examination. And probably the first investigation they would do is a colonoscopy to ensure that you do not have an organic pathology such as cancer that is causing your constipation. After which, we would then go on to perform further investigations to see if there are any pelvic floor disorders that are correctable, such as a rectal seal or a rectal interception, that we can then address primarily to help you with your constipation. To answer your question, does it affect your pelvic health? Chronic straining during constipation can further weaken your pelvic floor muscles, as well as worsen pathologies such as a rectal seal or rectal interception. So in a sense, it may have like some indirect effect on your pelvic floor muscles. So to answer your question, how do we cure this constipation issue? Please seek medical advice early, and then we can do the necessary investigations and work with you to help you with your symptoms.
Thank you, Dr. Ng, for your advice. We also had quite a few questions earlier on regarding urinary symptoms at night. So there were some questions about urinary frequency and incontinence, specifically at night, and whether going to the toilet twice at night is considered abnormal. For this question, would Dr. Lee Xin Yi like to give us her input?
Thanks for the question. Okay, so basically, right, they usually for the definition of nocturia or more frequent urination at night, usually it will be more than one time, so twice and above. Okay, but this also has to take into account the number of hours that you actually sleep at night. Okay, and also whether or not the waking up to go to the toilet is a pure factor of going to toilet because you are urgent, or whether it's a matter of some poor sleep or other reason that cause you to wake up, and as a matter of habit you then go to the toilet, you know. So if let's say the number of times that you pee at night is many times, but it's not purely because of having urgency of urination, then it may not be considered as a what we call a nocturia problem. Some of the advice that we can, the common and simple things that we can do to reduce the number of times that you have to wake up and go to the toilet at night would include things like restricting the amount of fluids you take right before bedtime. Okay, we usually will advise to consider not drinking large amount of fluids at least 2 hours before your sleeping time. So try to space your dinner also away from your sleep time, and also during the dinner watch what you eat, in the sense that you may want to reduce the number of fluidy type things like soups and high water content fruits, for example watermelon, during your dinner diet. And some of us do have, I mean, given our age and all that, you know, we have a high cholesterol, and then we are told to eat our statins at night and stuff like that. So we will also advise to just take any night medications with a small sip of water instead of taking one large glass of water. And in the same vein of action, if you were to wake up at night because you have to pee or something like that, some of us also have the habit of drinking one big cup of water after coming back from the toilet and before going back to bed. So of course we would recommend to either not drink it all together or just take a small sip if you feel that your throat is dry. Yeah, thanks.
Thank you, Dr. Lee. There was also a question on whether or not removing the uterus affects the pelvic floor, and does it help to release the weight from the pelvic muscles? Can I invite Dr. Jill Lee to address the question?
Hi. So a question about removing the uterus. I think it depends very much why the uterus was removed. So there are many reasons why the uterus may need to be removed. For example, if there was a very large uterus with very large fibroids or other masses that were growing on the uterus, and that can put pressure on the pelvic floor. And sometimes and removing that actually can reduce the amount of pressure on the pelvic floor muscles. However, there are also women who remove the uterus as part of their treatment for pelvic organ prolapse or for other reasons. And in these cases, sorry about that. Sorry about that. So if in the case where women are removing the uterus for a normal size uterus, that doesn't actually reduce pressure on the pelvic floor because the normal uterus volume is only about weight is probably only about 80 to 100 grams, and this would not be a significant burden on the pelvic floor normally. However, cutting the ligaments that usually support the uterus will also sometimes weaken the pelvic floor muscles and can result in what we call post-hysterectomy vaginal vault prolapse, which is a form of pelvic organ prolapse. I hope that answers the question.
Thank you, Dr. Lee. The last question would be for Ms. Hui Shu En. I think there were also many participants that were interested regarding the type of exercises that they can do. I think there was a question about heavy lifting. So usually we would advise to avoid heavy lifting, but what is considered too heavy? And is it advisable to do deep squats? Can I invite Ms. Hui to address the question?
Yes, thank you for the question. So we talk about the types of exercises, how heavy to be lifting, what types of exercises. There's really no hard and fast rule about what you should not do. I mean, in principle, we know that activities such as jumping, running are higher impact sports. So these require a lot more load on the pelvic floor muscles. So then they require the muscles to be a lot stronger for you to be able to manage them well. But for some people whose strength with pelvic floor muscles are not that great, then that's potentially when they might have more leakage of the urine or even more symptoms when they do that. So ultimately, it is important to be staying active, to do different types of exercises to maintain strength in your other muscles, overall health, and make sure you have good endurance and cardiovascular strength and endurance. Exactly what type of exercise to do, I would suggest to kind of go slow and gradually progress. It's never advisable to go too hard or too fast. Monitor your symptoms when you're doing the exercises and after you do the exercises. If let's say your symptoms are okay, you're not having any much of the leaking, you don't have much of the heaviness, prolapse kind of sensation, then I would say that it's okay for you to continue with the exercise. But if you find that when you do a certain type of movement or activity, you have worsening leakage or even worsening symptoms, then I would suggest to consider an alternative form of exercise that can strengthen that group of muscles. If you're still in doubt, you can probably consider to contact your physiotherapist to discuss further on how we can find a different way to strengthen your body and other muscles without worsening your leakage or your symptoms. Thank you.
Thank you, Ms. Hui. Okay, so we have come to the end of today's forum. Thank you to all our speakers for the engaging discussion and the talks. We hope that everyone has learned a bit more about pelvic floor health and gained some useful information on urinary tract infections, incontinence, and constipation. Also, we would also like to hear from you. If possible, you can scan the QR code to give us some of your feedback. Yeah. Thank you everyone for attending our public forum today, and we hope to see you next time.